This is E. David Crawford. I'm a professor of urology at the University of California, San Diego in La Jolla. I am also the chairman of the Prostate Conditions Education Council. In the next few minutes, I would like to give you sort of an overview of how we began, our journey, and where we are right now and our hopes for the future. If we go back to 1989, then at that time, prostate cancer became the #1 cancer diagnosed in American men and the second leading cause of death. Unfortunately, we were finding so many advanced cases and we questioned why. And really the reason was we were not finding the disease early, we were not screening. I had the opportunity to work on a new drug for prostate cancer in the late 80s and into 1989. And it was a drug was hormone therapy. Like, I took care of a patient who came for the study from Las Vegas, and his name was Perry Lieber. He was 75 years old, had advanced disease, and said, "Dr. Crawford, why is it that we don't find prostate cancer early?" And we talked about it. And I said, well, one of the reasons there's not a lot of public knowledge about it, and men don't come in for screening. But, at that time, PSA was just coming out. Breast cancer is decades ahead of us in a lot of things, and they were ahead in prostate and screening. They had spokespeople talking about breast cancer, Happy Rockefeller back then, and Betty Ford and others. And there was a real movement to do something about it. We didn't have that with prostate cancer. Perry was Howard Hughes's director of operations. He was the guy that got things done. He said, "Dr. Crawford, we need to start something. We need to start a national campaign. We need to stop this disease in its advanced stages." And so that led to the concept of what we called back then Prostate Cancer Awareness Week. Our goal, working with him and some other supporters, was basically to get out there and educate men about how common this disease was, and that if it was found early, we have a chance of curing it. And unfortunately, we couldn't find a man that would talk about his prostate cancer. There were a lot of famous men that I knew of that had prostate cancer back then, including Bob Hope and others, but they didn't want to talk about it. So we found a guy named Rocky Bleier, who was a Pittsburgh Steelers football player, and his grandfather, that was the closest thing we could come to, had prostate cancer. He was great. This led to our first Prostate Cancer Awareness Week in September of 1989. And we had a total of about 10,000 men around the country come in. We thought that was a great start. The next year, it was 100,000. And it's grown substantially since then. So since 1989, we have learned a lot. First of all, we learned that we have a great test, PSA. PSA is a test that is very sensitive, but it's not real specific. In other words, if you have an elevated level, you could have prostate cancer, but it doesn't necessarily mean you do. And I'll come back to that in a minute. So then that led to a cutoff of 4 as a abnormal PSA. And that was based on a study that was done in San Diego, of all places, by a company called Hybertech that started PSA in the United States and first marketed it. And what they did is that number of 4 came from 800 men and women over the age of 40 with no prostate disease. And that was how that number came around. And so we've learned that it's actually served us pretty well. It's a higher cutoff, but now we've lowered the cutoffs. We feel 1.5, other people feel 2. And there's a national effort to get men in and get screened and get a digital rectal exam. I had the fortune of working with a lot of great people. Bob Dole, working with Dr. Norman Schwarzkopf. He and I were on Good Morning America and a number of shows together. And I remember how forceful he was about men, get in there and get checked for your prostate cancer. Need to do that. And it's successful. We were getting men in, it grew, and we learned a lot over the ensuing couple of decades about early detection. We learned about PSA changes. We call that PSA velocity. We learned about new cutoffs. We learned about different forms of PSA and so forth. But the most important thing was we got men in to get detected, and they did. And we're not the only people that did that. Dr. Catalona out of St. Louis and many others were involved in early detection efforts. But we were one of the largest, and still are the largest screening event for any cancer in the world. So we were successful. We got men in, we found them. Well, what happened was we saw that the mortality rate, or rather the number of new cases of advanced prostate cancer, went from almost 80% down to 9% over the years. But along with that came a challenge. And the challenge was that we were finding a lot of men who were biopsied to have prostate cancer who probably didn't need to be treated. And what we learned is that if you take 100 men age 70 sort of off the street and you could somehow examine their prostates, you'd find maybe 40% or more would have prostate cancer. Most of them would never know about it in their lifetime. And so that was the challenge. It was overdiagnosis and overtreated treatment. Then we got a lot of new treatments, and then we got the people that were claiming things with all these different treatments and driving patients towards different types of radiation and surgery and things like that. But mixed with those patients were a lot of men who needed to be treated, and there were men who didn't need to be treated. And so what happened is that a government agency and others, but the government agency was called the U.S. Services Preventive Task Force, and their job was to develop guidelines for family practice doctors on things to do, like what blood pressure to treat, what's a bad weight, what's appropriate screening for colon cancer. And what they said about prostate cancer, they were watching it very carefully for a decade, and they came out and said, hey, look it. We think that there is a benefit from prostate cancer, but there are harms, and the harms outweigh the benefits. And that is the harms of surgery and radiation and side effects versus the benefits of finding the people and treating them and curing them. Well, that led to a lot of discussion and a lot of sort of fireworks fired on both sides of the fence. But I think that group was right. We needed to bring the pendulum back down to the center. And in fact, that's what happened. Over the years, what we've discovered is we sort of put the brakes on doing too many biopsies and things like that. But the good thing is, out of all of this over the years, we've learned a lot. And what we've learned in prostate cancer is this. We want to find men that need to be treated and can benefit from treatment. So there's a lot of parallels in medicine where you do one test, and then if that test is abnormal, you do another test. When you go to your family practice doctor and they find an elevated blood sugar on you, what they do is they do another test, and it's called an A1C hemoglobin. That determines if they're going to treat you with different anti-diabetic drugs, metformin, insulin, and a whole bunch of new things. Now, another parallel is an abnormal cardiogram. You don't necessarily get rushed off for a bypass. You get a vessel study before. So our feeling was an abnormal PSA, and our work has shown that 1.5 is a good cut point. Doesn't mean that if it's above 1.5, you have a problem, but 1.5 to 4 is a danger zone. And it could be that the reason that it's elevated is size of the prostate. And that's the most common reason. The most common cause for an elevated PSA is size of the prostate. As the prostate grows, so does the PSA. But hidden in there are men with cancers. His PSAs are also going up, and we have to distinguish those. And that's why having things like these new tests, these molecular markers that you do when the PSA is abnormal before you do a biopsy. And there's a whole host of those out there. There are urinary markers, there are blood markers and things like that. And they are gaining a lot of traction for us to be able to say, hey, if this marker is abnormal, then we need to consider doing a biopsy. We're also doing some great things with MRIs and other things like that to help us determine it. We're in the stage of molecular diagnostics, and we have a PCEC has a website with this, takes you through this whole algorithm and all these different urinary tests that are out there. Select MDX is a urinary test. We have other ones out there. We have 4K and we have Phi, and we have a number of different ones out there and new ones that are coming along. These all help us determine who needs to be biopsied. And then we even have ones that help us determine who needs to be treated. So we've learned a lot since 1989 when we started Prostate Cancer Awareness Week, and now we're the Prostate Conditions Education Council. Why? Because it's just not prostate cancer we deal with, but also enlarged prostates and what we call BPH, which is even more common than prostate cancer. So we have again, this is Prostate Cancer Awareness Week, Prostate Cancer Awareness Month now, all over the country and the world. And we want to continue to fight this battle. And we've got so many exciting things happening with new immunotherapies, new treatments, new ways to follow people. One of the things that I'm sure you're all familiar with is with genomic and genetic testing, the Angelina Jolie story with BRCA1 and 2 mutations. Well, you know what? There's a similar number of those mutations in men with prostate cancer as there are women with breast cancer. And we're just beginning to uncover this, the whole realm of germline testing and inherited disease. 23andMe, everybody's heard of that, but they don't test for the same BRCA1 and 2. So don't just rely on that. There are other ones out there. They're very specific that look at 20, 30 different markers of inheritance. Why is that important? I'll tell you a story and then I'm going to go ahead and stop and take questions. Several years ago, I took care of a 48-year-old man who was in great shape, except he had a prostate cancer. He had sort of an intermediate grade. He was 48, that's young. He needed to be treated. And he did. I did a radical prostatectomy on him. Did very well. Comes back 2 years later with a melanoma on his back. And I go, oh, geez, that's not good, but it was treated. They got it early and did okay. Comes back 5 years later, which was just a couple of years ago, and said to me, Dr. Crawford, it's very sad. My sister died of what we call triple negative breast cancer. At that time, I knew about germline testing, and I said to myself, wow, I could have saved that man's sister's life maybe if I knew about this and acted on it. Tested him, he was BRCA2 positive. So that runs in the family. If his sister, she was also BRCA1 positive. Had we checked him to find out that he was BRCA1 and 2, 2, and then sort of opened up the discovery within the family tree, you find those things. Another example is that my wife died at age 50 of ovarian cancer. That is something that is a big red flag for germline inherited mutations, not for me, but for my sons. And all three of them were tested. And so, again, there's a lot of things happening in prostate cancer. We're glad you're listening to this, and we still need to get the word out about properly finding men who need to be biopsied and who need to be treated. Thank you.